pleasure to welcome Jonathan Barrett, Professor of Renal Medicine. He leads the Renal Research Group within the College of Life Science, University of Leicester. An important field of his research is IgA nephropathy. He is the IgA nephropathy Rare Disease Group lead for the UK National Registry of Rare Kidney Diseases and a member of the steering committee for the International IgA Nephropathy Network. It's an honor having Dr. Barrett among us today, talking about IgA vasculitis. Thank you so much, Dr. Barrett.
So once again, it's a great pleasure to be here. Thank you very much for inviting me, and we had a wonderful dinner last night, so thank you to the hosts. So what I'm going to talk about in the next 20 to 30 minutes is IgA vasculitis, and I'm going to compare it to what we know about IgA nephropathy. So IgA vasculitis is the commonest vasculitis in children in the world, and I don't know if there are any pediatric nephrologists in the room. Are there any pediatric nephrologists? Mm-hmm. Good, excellent. So what my pediatric colleagues tell me time and time again is that children are not small adults. So even though this is a disease that is much more common in children, I'm going to restrict myself to adults. We can't necessarily think that everything that I'm going to tell you now applies to children. It might do, but we can't assume that. IgA vasculitis is a systemic disease with the classical tetrad of a purpuric rash, gastrointestinal involvement, renal involvement, and joint involvement. I'm really going to focus on the kidneys today and not discuss much. I will mention the skin because we've done some research in the skin, but really not touch much on the joint or the gut involvement. So Henoch-Schönlein purpura, which is what this used to be called, is named after two German pediatricians, Eduard Henoch and Johann Schönlein, and they practiced in the 19th, early 20th century. But actually the disease was described much earlier by a London physician called William Heberdine. And he described this young boy, and it has all the features of IgA vasculitis. A young boy, pains and swellings, presumably reflecting in the joints. He had pains in his belly, his urine was tinged with blood, and his skin and of his legs were covered with bloody points. That's a very descriptive explanation of what he was seeing in terms of IgA vasculitis. He didn't know what it was, but that is the earliest description by a clinician. Now, a test for everyone in the room. Who is this? Mozart. He's probably the first person I can find that has likely died of IgA vasculitis. If you read the medical notes that were recorded at the time of his death, he had all the features of IgA vasculitis. So when we think of IgA vasculitis and IgA nephropathy, there are clearly commonalities around epidemiology, clinical presentation, etiology, pathogenesis, and perhaps treatment. So there is a great degree of overlap, but there are also things that we only see in IgA vasculitis and patterns that we really are restricted to IgA nephropathy. But of course, the fundamental common feature that we see on the kidney biopsy is the mesangial deposition of IgA immune complexes. And we cannot distinguish a kidney biopsy from IgA nephropathy from IgA vasculitis, and often the pathologists will ask, has the patient got a skin rash? Because it's not written on the form. And of course, it's the clinical features that determine whether this is an IgA vasculitis pattern or a kidney-limited IgA nephropathy pattern. The one thing that I'm part of in the UK is a Facebook group for UK patients. And one of the patients asked, I hear a lot about Henoch-Schönlein, purpura, IgA vasculitis, what is it? And so I put up a picture on the Facebook group of a typical rash for HSP. And a number of patients replied, do you know what, I had that rash when I was a child, and it came and it went away, but then subsequently I forgot about it, and I've been found to have IgA nephropathy. So I think there is a lot of IgA vasculitis that may occur in childhood that is a brief vasculitic rash that resolves, and patients then don't present, but present later with blood and protein in the urine and a diagnosis of IgA nephropathy. So we really don't understand that, but when we go looking for it, you'll be surprised how many of these people we think have IgA nephropathy actually remember having a vasculitic rash when they were children. So this is what we understand at a high level is the pathogenesis of IgA nephropathy. And I'm going to talk through that and then relate that to what we understand about IgA vasculitis. And so the central feature in IgA nephropathy is the presence in the circulation of IgA containing immune complexes that are prone to deposit in the kidney and trigger inflammation and scarring. And actually when we look, we can see those immune complexes are equally relevant in IgA vasculitis. And so here is some kidney tissue that has been stained for IgA immune complexes, looking specifically for that abnormal form of IgA, Gd-IgA1. And you can see here in these IgA vasculitic patients, this KM55 antibody recognizes those specific IgA molecules. You can see that there is staining in the IgA vasculitis kidney, and there is no staining in lupus nephritis cases. So those immune complexes appear to behave very similarly. And actually, we've done a study with Cord Sunderkotter in Germany, who's a pathologist and a dermatologist, and we've looked in the skin of patients with IgA vasculitis, and we can see those exact same immune complexes deposited in the skin blood vessels associated with the vasculitic rash. And so, as I've said, the major substrate for these immune complex formation is this particular form of IgA. It's polymeric, so it has two IgA molecules stuck together with J chain, and it carries changes in the sugars at the IgA1 hinge region. And we can measure that in the blood, and we routinely measure that in IgA nephropathy, and we can see it's elevated. When we look in IgA vasculitis in adults and children, we can see that those levels are elevated as well. And in fact, they seem to be most elevated in those children that actually develop nephritis, rather than those that just have a skin rash. Again, suggesting that this particular form of IgA is relevant to both diseases. Now, we believe that this particular form of IgA comes from the mucosal immune system, so the immune system that lines our respiratory tract, our genitourinary tract, and our gastrointestinal tract. And I talked you through some data yesterday of the new drug Nefropatología, deliberately designed to target mucosal production of IgA. And indeed, in IgA vasculitis, we see a similar association. So you can see cases of HSP exacerbated by gastrointestinal infections. You can see here some of the data from the genetic studies talking about an association with genes related to the mucosal immune system related to IgA vasculitis. You can see exacerbations with COVID, exactly like we saw with IgA nephropathy. You can see associations with inflammatory bowel disease. And here you can see markers of intestinal permeability are increased both in IgA nephropathy and IgA vasculitis, again supporting a mucosal link in IgA vasculitis with the pathogenesis of this disease. We see here there's some very interesting data, and actually there was a whole session at the S.E.N. last year about the frequency of IgA vasculitis in patients on anti-TNF therapy. So anti-TNF therapy for inflammatory bowel disease or for psoriatic arthropathy. And there is that clear association, and you can see this here, but we also see it in IgA nephropathy. And actually, I'm looking after 2 cases at the moment of patients that have had significant inflammatory IgA disease in association with anti-TNF therapy. So that we don't understand why this happens, but we see that it happens both in IgA vasculitis, but also in IgA nephropathy, suggesting a common pathogenic pathway. Now, all of this develops on a genetic background. So the most recent genome-wide association study in IgA nephropathy identified over 30 different genetic risk alleles. Far less work has been done in IgA vasculitis simply because the number of cases is much smaller. But we do have data suggesting that there is a genetic component. So these are family studies of familial IgA nephropathy. We've got a French study here, and within that French study, there were families that had cases of IgA nephropathy and cases of IgA vasculitis in the same family. In this large pedigree from southern Kentucky, you can't really see it on the screen here, but in this pedigree, you have patients with IgA nephropathy and you have siblings that develop IgA vasculitis in the same family. And that occurs in multiple families, suggesting there is a shared genetic risk for both diseases. And if we tease a little bit into a little bit more detail, what seems to be the case is that in IgA vasculitis, there is a sharing of those genetic risk alleles with IgA nephropathy, but there is also a sharing of those genetic risk alleles associated with more general vasculitic diseases. And so this is the most recent genome-wide association study from Christoph Kirilluk, published at the end of last year, identifying, as I say, over 30 different genes, and some of those are shared with publications that have identified genetic risk factors in IgA vasculitis. But equally, you can see in this study here, there were genetic risk factors identified in Kawasaki's disease, a type of vasculitis, that were also seen in IgA vasculitis. So there is this overlap. Now, we don't understand it completely, but IgA vasculitis seems to share risk alleles from both of these distinct disease groups. And that's why you're seeing an almost hybrid disease having features of vasculitis, but also that mesangial deposition that you see in IgA nephropathy. This is something that isn't published yet. It was presented at the International IgA Nephropathy meeting in Tokyo at the end of last year. And this is the largest genome-wide association study in IgA vasculitis. And you won't probably be able to read it at the bottom, but actually what this study found, which is really interesting, is there are genetic risk alleles associated with the Fc alpha receptor. So the Fc alpha receptor is an IgA receptor expressed on myeloid cells, and in particular on neutrophils. And of course, we know the importance of neutrophils in the setting of systemic vasculitis. It's also associated with polymorphisms in the IL-6 receptor. And IL-6 is clearly a very pro-inflammatory cytokine. And then in another protein here, which is associated with intracellular signaling. And this is not seen in IgA nephropathy, suggesting that in IgA vasculitis, they have genetic risk factors that are related to the intensity of inflammation and the ability of myeloid cells to interact with IgA. And I'll come on to that. And so what happens when the IgA eventually deposits in the kidneys? Well, you can see here in IgA nephropathy, it triggers mesangial cell proliferation. That releases, and the mesangial cells release pro-inflammatory cytokines and chemokines. That recruits into the glomeruli inflammatory cells, monocytes, macrophages predominantly. And you can, in some cases, get an uncontrolled inflammatory response with crescent formation. Those immune complexes and pro-inflammatory and pro-fibrotic mediators can cross the glomerular basement membrane and interact with podocytes and tubular epithelial cells and drive phenotypic transformation, pro-inflammation, pro-fibrosis. And what we've identified more recently is that these immune complexes can cross the glomerular basement membrane as well and directly interact with podocytes and tubular epithelial cells. And of course, all of this is amplified by activation of the complement system. And these features, which we replicate in the laboratory all the time, are the features in the kidney biopsy that are part of the Oxford classification. And we know each of these features independently predicts the risk of kidney failure. So the M score, the E score, the C score, the S and the T score. So this is what we understand is happening in IgA nephropathy. So what evidence is there that similar processes are happening in IgA vasculitis? So there have been some studies, but not many. And what this study here is a proteomic study looking at the expression of proteins in glomeruli in IgA vasculitis. On this principal component analysis, you can see here healthy kidney tissue, You can see here IgA vasculitis and IgA nephropathy. You can see there's a lot of shared upregulation of proteins, but there are distinct proteins that are being seen in IgA nephropathy and IgA vasculitis. Now, this is a small study, but it's starting to show there are significant commonalities, but also differences. And if we move next to this study of transcriptomics, again, but looking at IgA vasculitis, IgA nephropathy, but this time also IgA dominant infectious, post-infectious GN, what you can see here, and I just want you to concentrate here, is that if you look, you can see here, there are clear separations in terms of the different groups. And you can start seeing some common transcriptomic signatures, but you can see distinct signatures as well. So it may be that in the future, with more detailed high-resolution evaluation of the kidney biopsy, we might actually be able to distinguish IgA vasculitis from IgA nephropathy. But at the moment, with the way we look at the kidney biopsy, we're not able to do that. Complement appears to be as important in IgA vasculitis as it is in IgA nephropathy, and here you can see the studies that have been published exclusively in IgA vasculitis showing dysregulation of the complement pathway both in adults and in children. So no surprise there, the complement pathway is as important. But what is it that's different? Because clearly patients with IgA vasculitis behave differently. And so again, this is some work we did with Cord Sunderkotter. And what we did was we collected blood and we purified the immune complexes from patients with IgA vasculitis during a flare and when they were in remission. And then we exposed neutrophils to those immune complexes. And what we found was that when we exposed neutrophils to the IgA immune complexes during a flare, that led to significant neutrophil extracellular trap formation, net formation, and this is a endothelial cell culture. You can see lots of endothelial cell death, and here you can see that this didn't happen. So what we found was that the immune complexes were behaving differently during relapse and during remission. And the main effect we saw was their interaction with neutrophils, promoting neutrophil activation, promoting net release. And so what we've hypothesized is happening is that if you think about ANCA vasculitis, we all know about the importance of MPO and PR3 antibodies that prime neutrophils, and this is the fundamental pathogenesis that we see for endothelial injury. Primed neutrophils adhering to the endothelial surface, releasing nets and other inflammatory factors, causing endothelial damage and then ultimately a vasculitis. Now, unlike in ANCA-associated vasculitis, what we think is happening is that it is the IgA immune complexes that are priming the neutrophils. And it is changes in the IgA complexes that are determining the frequency of relapse. And so if you have particular types of immune complexes, they prime neutrophils and you get the vasculitis. And if you're in remission, those immune complexes subtly change. Now, we've done a lot of work doing LC-MSMS, so mass spectrometry, on purified immune complexes. And we know that the proteins within those immune complexes change, and those proteins determine how able those immune complexes are to activate kidney cells. And so what we're doing at the moment, we have a whole series of IgA immune complexes from people with IgA nephropathy, from IgA vasculitis, in relapse and in remission, and we are going to look at the protein composition of those immune complexes to see if we can relate what it is about those immune complexes that interacts with neutrophils in IgA vasculitis that then drives this process. And of course, the genetic risk alleles that Christoph identified in terms of the receptor that sat on neutrophils that will recognize this IgA, and the IL-6 receptor, which is a highly pro-inflammatory receptor, may well be the other side of the process increasing the risk of an inflammatory response that we don't see in IgA nephropathy. So watch this space, because hopefully we'll have that data before the end of the year. And so how do we treat this disease? Well, we included IgA nephropathy and IgA vasculitis in the 2021 KDIGO guideline. If you were expecting to understand how to treat IgA vasculitis in this guideline, you will be very sadly disappointed. And the reason you'll be disappointed is because we have very little, if any, data. There have been very few studies in IgA vasculitis, both in adults and in children. So I'm going to talk you through where we are, where the knowledge gaps are, and what is happening to try and address that. So this is the paradigm for IgA nephropathy: making a diagnosis, scoring with the MES score, risk stratifying, and then entering into a registry and looking on. And that's very clear in terms of IgA nephropathy, but in IgA vasculitis, the MES score had not been validated. I know a lot of people use it, but we had no data. We've just had, and I don't know whether you've seen, a study in CJASN from the International IgA Nephropathy Research Group from Mark Haas, who looked at the MES score in IgA vasculitis. It doesn't perform as well. There are certain lesions that are predictive, but it is not as clear-cut as in IgA nephropathy. So we do need to work harder to understand how we interpret the kidney biopsy and what that means for risk of progression. The International IgA Nephropathy Risk Prediction Tool has not been validated in IgA vasculitis, so we shouldn't be using it in IgA vasculitis, but we don't have any other risk prediction tools. So how should we treat? Well, the only thing we can actually say with any confidence is that if you present with a rash, there is no point giving systemic glucocorticoids to prevent the development of nephritis. And that's actually been studied in randomized controlled trials, particularly in children. So the pediatricians, and I hope I'm right here looking at the pediatric nephrologist, is if you have someone with just a rash and no nephritis, there is no evidence that giving them steroids is going to stop them developing nephritis. Different matter if they have nephritis, but that's probably the only thing we can say with any degree of confidence in the management of IgA vasculitis. So this is where we start just using what we know about IgA nephropathy. So it doesn't seem unreasonable that if you have someone with a nephritis and impaired kidney function, you will want to do those things we talked about yesterday, which is the general CKD management. That seems pretty fair, pretty okay. But what do we do in those patients at high risk that we all worry about? Well, really, there is no data. There is no data on the right type of immunosuppression to use. There is this data looking at rituximab. It's a collection of clinical cases suggesting that there may be a benefit of rituximab in IgA vasculitis that we haven't seen in IgA nephropathy. It is a selection of case reports. It's not a trial, but it is something, and these are adults. So this is something that is out there. We comment on it, but it's really not high-quality data, and it's prone to a lot of bias in terms of how the study was collected. What do we say about someone with IgA vasculitis and rapid progression and RPGN? Well, we say treat as ANCA vasculitis. We've got really no data. That is just what we thought of as expert opinion. And that's probably what you guys do anyway. If you have someone with IgA vasculitis and rapidly progressive kidney loss, I would imagine you treat them, certainly in adult practice, as if they have an ANCA-associated vasculitis. This is being looked at in terms of the management of IgA vasculitis by a European IgA vasculitis study group under the auspices of UVAS. And we have met recently at the vasculitis meeting, The group contains adult and pediatric nephrologists, dermatologists, pediatricians, pathologists, and essentially the idea is that we will come up with a guideline that allows us to define how to diagnose IgA vasculitis, how to assess organ involvement and severity, how to treat IgA vasculitis, and how to follow up patients. So that is the goals of this group. Of course, the challenge is they can only work on the publications that are around, and they were the same ones that were around when we did the KDIGO guidelines. So it is going to be a lot of expert opinion without any solid data to base it upon. But you just need to be aware this is coming, and there are work groups now that are going to define all of these, and there will be a publication, as you've seen for other forms of vasculitis, that may well be useful to use in clinical practice, certainly to use in clinical trials if we do any. So IgA vasculitis is the commonest vasculitis in children, and what could we say about children in this document? Well, we said treat as adults, because we didn't have anything else. We had 2 pediatric nephrologists in the group, and really, again, there was no data for them to be able to offer any evidence-based recommendations. So what we say is to treat as IgA nephropathy, which is completely unfair because they are different diseases, but in the absence of data, we really struggled. But what you also need to be aware of is that there has been an IPNA group, this is in the final stages of publication. So I was an adult nephrologist, part of this group, and there will be clinical practice recommendations for the diagnosis and management of children with IgA nephropathy and IgA vasculitis. And what I would say, it was like talking to people who managed a completely different disease. So from an adult perspective and a pediatric perspective, how you approach this disease is completely different. And so I think it's going to be really interesting when these come out and you compare them to our approach in adults. But these are coming. Again, they're based on exactly the same data we had for KDIGO. There's no magical new trials, and it will be very much expert opinion. So where do I think we're going to go? Well, I think you saw this yesterday. I think we need to think logically about this disease. I think we need to think when we have a diagnosis, if a patient has got a diagnosis as an adult of IgA vasculitis with nephritis, we do exactly the same thought process that we do with IgA nephropathy and any other form of glomerular disease. We address those generic drivers, and we address the immune drivers, and we do those simultaneously. All of these generic drivers are exactly the same. The only issue compared to IgA nephropathy is we have no data for SGLT2 inhibitors, because patients with inflammatory glomerular disease were excluded from the SGLT2 inhibitor trials. Doesn't mean to say they don't work, but any patient likely to need immunosuppression was not included in the SGLT2 trials. And we don't have any data on sparsentan or any of these specifically in IgA vasculitis. But I don't think there's any reason to suspect they won't work, but we just need to be aware we don't have data. We then need to do exactly what we want to do in IgA nephropathy. We want to reduce those IgA immune complexes, and we want to treat inflammation. And certainly in the adult cases I see, inflammation is far more of an issue in IgA vasculitis than it is in my IgA nephropathy patients. And this is going to be particularly important. And in fact, when you look at the expert guidance, the first-line treatment for IgA vasculitis is in fact systemic steroids. Even though there's no evidence, there's no good trial data, expert opinion is if you have a patient, an adult patient with IgA vasculitis, a consideration of systemic steroids, and really as an anti-inflammatory. We hope we're going to convince the companies to come in and look at complement inhibition in IgA vasculitis, but those patients have been excluded from those trials. We have no data on Nefropatología or any of the BAFF/APRIL inhibitors or the depleters in IgA vasculitis. They've all been excluded from the clinical trials. But I think those patients are as likely to respond. And actually, in clinical practice, certainly in the United States, where they've had Nefropatología for far longer, they are using that in IgA vasculitis and seeing good results. But we have no data. But this is where we are. We know what we want to do, but we have not got access to drugs, and the drugs aren't being evaluated to know whether they work. And so just to finish, this is data from clinicaltrials.gov a couple of days ago. So these are the number of studies in IgA nephropathy currently recruiting. And there's over 170 of them. And you can see where they are. Okay? These are the number of studies in IgA vasculitis. Just studies. Okay? I'm not saying trials of new therapies, I'm just saying studies. These are the number of phase 2 or phase 3 trials of new therapies in IgA nephropathy currently recruiting. And I'm sure this probably reflects the kind of studies that you're looking at here. These are the number of phase 1, phase 2, phase 3 studies in IgA vasculitis at the moment. These are not studying new therapies. These are studying old therapies in small pockets of single-center studies. You can see how much clinical trial activity there is. In China, the studies are looking at Chinese herbal medicines, not Western medicine. So there is very little clinical trial activity in IgA vasculitis. These are the number of trials for the pediatricians in the room in children. This is a disaster area for new therapies in terms of children. We've got one study, and that's complete, that's almost full, that's finished. 2 studies in China. These are the number of studies in IgA vasculitis. It's the same study. That's it. So I wish I could tell you that in 3 years' time, if I were to come back, I'd tell you all sorts of fantastic, wonderful data about IgA vasculitis, and we'd know what to do. But this is where we are at the moment. And so we must do better. We are desperately trying to work with the companies designing the trials to include IgA vasculitis. But at the moment, it is a really bleak outlook in terms of how we are going to generate new data for new therapies in this disease. And we just need to keep the pressure on to start thinking about how we can leverage the excitement that's going on in IgA nephropathy and transfer that to IgA vasculitis. But it's going to be a hard job. So I thank you very much for your attention, and I'm happy to take any questions.
Thank you very much, Dr. Barratt. Any questions? I would like to ask you, because in few months or years, we are going to have a lot of new therapies for IgA nephropathy. You told us the different targets. But what is your personal thought about the target in IgA vasculitis? Will you give a priority of the complement inhibitions, like for example, avacopan for vasculitis? And there is some evidence for IgA nephropathy, so maybe you will give a priority that kind of drugs, or maybe anti-APRIL like sibeprenlimab. What is your thought for the new years?
So I think avacopan would be perfect for IgA vasculitis. Really do. I think my gut feeling is we will get all these studies in IgA nephropathy. The drugs will be approved. Companies are lukewarm about going into IgA vasculitis, and we as nephrologists will probably end up running an academic study. So I think we will, as academics, and I think it's a real opportunity to think, how do we design a study, perhaps across Europe, and I still count the UK in Europe, as a way academically to test these new therapies in IgA vasculitis. But I think avacopan would be perfect, and I think Nefropatología and I think the BAFF/APRIL drugs will be perfect. But I don't think the companies are going to do the study, unfortunately. It's going to be reliant on us to do an academic study to show benefit.
Thank you so much. Fernando?
So my question is also related to complement and the involvement in the pathogenesis. So is the complement primarily involved, or is kind of the susceptibility to develop the IgA vasculitis, or is it activated after being primed by neutrophils and this beautiful interaction that you already showed us?
So I think complement is as important in IgA vasculitis as it is in ANCA vasculitis. I think actually in IgA vasculitis it's possibly even more, because we have the immune complexes and we can see the C3 actually stands out, doesn't it, on a kidney biopsy, whereas in ANCA vasculitis you have to really look hard to see complement deposition, but we know complement is important. So I think complement is going to be the major driver for glomerular inflammation in IgA vasculitis, which is why I think complement therapies will be a fantastic acute treatment. But we also need that B-cell directed therapy. And there's that data in rituximab. I'm not so sure. They were not very severe cases. But I do think we need to think about what we do as well as block complement. And that's going to be whether the Nefficon, whether the April BAFs are going to be useful for us. And I just think we would view this in exactly the same way as ANCA vasculitis, as IgA nephropathy. Block inflammation. Inflammation is going to be far more common in IgA vasculitis than it is in IgA nephropathy. I would imagine in my population, 1 in 10 patients is likely to need an anti-inflammatory, because I just don't see it on my biopsies. Whereas in IgA vasculitis, I would suggest 95% plus are going to need an anti-inflammatory. They're all going to need a B-cell directed therapy, though, to switch off the pathogenic IgA. That will be the common theme, but the complement inhibition, I think, will be virtually uniform in patients with IgA vasculitis. And of course, what we don't know is whether that will help the skin or whether that will help the gut or the joints. So that's going to be really interesting to see.
Yeah, and another question is, the IgA Nephropathy International Network have already shown in a CJSON manuscript. It's led by Sean Barber. I don't know if you recall. But this study showed in a large retrospective cohort that there are sort of two profiles of patients, those who have a pretty benign clinical course, and whereas there's another profile in which there is sort of an increase in EGFR, but a late decrease and potential development in the long term of end-stage kidney disease. So how to predict what patients could do better or worse, and therefore how to titrate the intensity of immunosuppression depending on those profiles?
Yeah, so I think, so first of all, in children, the GFR goes up before it goes down. So that's very different to adults. What we're seeing in the trials in IgA nephropathy of anti-inflammatories is actually an initial increase in GFR and going down as you have that anti-inflammatory effect. We don't know how to handle that at the moment, and that's going to require much more data and much longer follow-up. You've got to remember the data that Sean had is really only out to 5 years. And that's a relatively short period of time. But you're absolutely right. How we look at that initial response, it might be that if you give these drugs and you have a nice increase in GFR, that's going to predict those that are going to do very well. Just like we know if you have a big drop with a RAS inhibitor, you're actually going to gain more benefit over the long term. But we just need to have that data to really drill down there.
Thank you for the excellent talk. I have a question about IgA dominant nephritis related with infection, staphylococcal infection, because I have seen several patients with, in general, with a very poor outcome, despite not particularly aggressive histological lesions, and even after resolution of the infection. So, and in general, in the literature, you can find in general a poor outcome. What do you think could be the reason for such poor outcome?
So that's a great question, which we really don't know the answer to. And it's usually a Staph aureus, and it's whether those IgA antibodies are actually IgA antibodies against the sugars on the cell surface of those bacteria, and those antibodies then cross-react with other antibodies in the circulation to form immune complexes. And when they deposit, they behave just like a post-streptococcal, post-infectious GN. They do very badly. We really don't understand why they do so badly. It's most commonly in elderly people, in diabetics, but it's a really interesting question, but no one's really looked in great detail at those cases other than just report clinical outcomes. Yeah. You have the classical subepithelial humps. They have the same pattern as you'd see in post-strep, but they clearly do much worse. And it may be simply that this is something that is seen in older people with multiple comorbidities rather than post-strep, typically being young children, where it's very quick, they resolve and they're able to recover more quickly. But we don't know the answer to that.
Thank you. Another question is, Dr. Eduardo Gutierrez sent me yesterday a paper about a good series of cases from Chinese, in Clinical Kidney Journal, with tacrolimus in IgA vasculitis, a good series with good outcome. No? And this is curious for me because some doctors have commented me good responses to tacrolimus in IgA nephropathy. Doctors that don't read KDIGO guidelines, no? But I have no personal experience with CNI, calcineurin inhibitors in IgA nephropathy, but do you have any experience or what is your think about this?
So in those patients with IgA vasculitis and actually in IgA nephropathy who we think have a podocytopathy, then the CNI can be useful, particularly with heavy proteinuria. So I have seen it used in that setting. But in general, non-nephrotic patients, I've really seen no evidence of benefit. But again, it may be that approach is useful in children. And of course, we've got to remember, IgA vasculitis is as different in China as IgA nephropathy in terms of how it looks compared to what we see in European patients, and that's likely related to the genetic background on which this disease develops. So there may be a role for CNIs in Chinese patients, but I'm not aware of any data outside of those with a podocytopathy and heavy proteinuria.
Last question.
We know that there is a limited kidney disease in ANCA-vasculitis. ANCA-vasculitis with renal involvement, but no skin involvement and not other organ involvement. But in IgA nephropathy, some cases of IgA nephropathy with a very rapid progress disease, we can speculate that maybe we are we are facing an IgA vasculitis, but without other organ affected. In this case, my impression is that in this patient, we are undertreated this patient because we consider that these patients are usual IgA nephropathy, but maybe this patient is IgA vasculitis. What is your opinion?
Yeah, so you know Alan Salama. Do you know Alan from UCL? He's very interested in ANCA vasculitis, and he says as well, is there a renal limited IgA vasculitis? And we don't know. I think we need to be much better. You saw those transcriptomic and you saw those proteomic studies. I think we may well get to the point where we can differentiate a vasculitic type pattern of injury from a mesangial proliferative type of injury. But we're not there yet. But I think we do need to think about how we better assess the biopsy to say, does this person need an anti-inflammatory? And we don't need to worry necessarily about what we call the disease. We need to go in and say, this is a significant degree of inflammation, let's treat it. Whether there's IgA deposits, whether it's porcine immune, it needs treating. I have a PhD student who has just completed his PhD doing digital spatial transcriptomics on glomerular endothelial cells from kidney biopsy tissue. And he has some beautiful signatures in those patients who have endocapillary hypercellularity. So he can see the endothelial cells are behaving differently when there are macrophages there than when there are not macrophages. And it may be that when we get down to that level of detail, we can start seeing different patterns of endothelial response that might be more reflective of a vasculitic process than a kind of slow proliferative process that we see more commonly in IgA. So I think it's a real opportunity that we may well be able to see that in the future.
Thank you.
Thank you so much, Dr. Barrett, for your wonderful talk and your answers.
Thank you very much, and thank you.